Thanks to the organizers, Dr. Munir, Dr. Ashraf, and all the wonderful folks here. Thanks for being here. To put it simply, I'm not here to answer that question, sir. I'm here to pose more questions. So, I think it goes beyond doubt that people with acute coronary syndromes, acute MI, for sure, they need to be intervened on in some manner. It has benefits in terms of hard endpoints like mortality. What about patients with chronic coronary syndromes, patients with stable angina? In the past, it was all about, I think, cosmesis. We felt like, putting stents into every artery was making the artery look good and therefore resulted in improvement in patients' longevity. But certainly that's not the case now. And there are few conditions where I think we need to intervene, either in the form of doing a bypass operation or of stenting. But most patients are actually well controlled with, and live just as long without symptoms with good guideline-directed medical therapy. So, when we talk about chronic coronary syndromes or CCD, chronic coronary disease, we basically look at 4 or 5 classes. One is anyone after an acute coronary syndrome who's been subsequently stabilized. What about patients with LV systolic dysfunction, which is proven or suspected to be of coronary artery origin? Patients with symptomatic stable angina, with or without proof of non-invasive testing to confirm its origin. Patients with proven anginal symptoms with microvascular or coronary spasm disease. And last, those asymptomatic people who have, by virtue of a non-invasive test, being diagnosed to have or have a suspicion of coronary artery disease. So we have a large spectrum of disease processes falling under CCD. So these were cases that we did in our cath lab in the last 6 months or so. And simply by a raise of hands, how many would intervene for these patients with these 4 kind of arteries? So on the right side, there's the right coronary artery, the circumflex below, and 2 left anterior descending arteries on your right side of the panel. So simply show of hands from in the past, most of us would end up intervening in these blood vessels. Patients with chronic coronary disease, what do we need to do? The first and most important thing, I think, is to risk stratify them. Subsequently, based on risk stratification, we decide on treatments. What are the variables that help us determine whether someone falls into a high, intermediate, or low risk stratification? Demographic variables of age, gender, etc. Social variables, a lot of the time affordability, insurance, these play a big and vital role in optimizing treatment for these patients. Medical variables, and we'll go through this, some medical conditions that make such patients more prone to getting adverse events in the future. All these patients, we need to validate them through certain commonly found risk scores, easily found on Google or any other of the computer apps. Based on what we find, we can subject them to further testing, either non-invasive or in a small percentage of people, invasive coronary angiography. So like in the past, where anyone with chest pain went into the cath lab and probably got an angiogram done to see what we can do, I think things have changed. What's our first line and the main line of treatment is medical treatment and lifestyle changes. If we have not optimized this, we are doing a disservice to these patients by taking them into the cath lab or doing any sort of procedure on them. You would only take these patients for an invasive cath lab if you find certain conditions. 1, you have unexplained LV dysfunction. 2, you have angina, which is refractive to optimum doses of medical therapy, recommended guidelines. 3, if there is something to suggest maybe significant left main disease, right? So these are the 2 or 3 conditions where you would actually take them for an invasive coronary angiography. In all other situations, you would try and optimize medical treatment first. So what are the conditions where socially we find that these patients are at higher risk? Certainly poverty, lack of social support. We see a lot of people in this part of the world, families back home or in some other part of the world, and they're here alone. Social support is lacking. Many of them have an insurance issue. They cannot have access to quality health care. Certainly advancing age is a high risk factor. People who have either proven atherosclerotic disease in the form of a previous heart attack, peripheral arterial disease, or heart failure, conditions like atrial fibrillation, and all the risk factors that we otherwise know is associated with a higher event rate. Biomarkers, patients with a high level of troponin, suggesting some chronic troponin leak, or BNP suggesting antecedent heart failure, and certain diagnostic criteria on testing. So if patients have a high Duke treadmill score, they have a low rate pressure product on stress echo, they have multiple areas of regional wall motion abnormality on the same, or studies with PET, cardiac MR, or a high calcium score. Any and all of these would make us suspect that these are patients who require maybe some more intervention over and above guideline-directed medical therapy. So this is a busy slide, but I think it's a good slide for most of us to remember, and that's the reason why it's here. All our patients that come in, the first and most important thing is to obtain a good clinical history and physical examination. If the patient has a history that suggests unstable angina, recent onset, minimal effort, at-rest angina, certainly you follow the non-STEMI or the acute coronary syndrome guidelines. What about patients who come with stable symptoms, class 2 symptoms? Here is where you would look at the other factors. So you do some blood work, you'd look at their biochemistry, you'd certainly get a resting ECG and an echocardiogram, and then decide what we next need to do. Right? Most important, some of these patients, are old, they're debilitated, maybe they have another history of some orthopedic problem or a cancer going. If their comorbidity impacts their quality of life, then the treatment still remains medical therapy. For patients who are otherwise fit, reasonably active, and this is not age dependent, you first look for any other causes for chest pain other than coronary artery disease. And if it is, like costochondritis, you might have pleuritis, pericardial effusions, some rib disorders, you treat that. Now, after all this, you reach the conclusion that, yes, indeed, this gentleman has, stable angina. Our next step is to assess the echo function. If the echo function is poor, which is less than 50, moderate or reduced ejection fraction, with typical angina, here is a case where we might offer a coronary angiogram as the first line of defense to see what we can do for this patient. In all other cases where the ejection fraction is normal, where the patient has stable angina, you would do a PTP, a pre-test probability for these patients, putting them into a low, intermediate, or high-risk category. Why do we do this? In patients with a low-risk pre-test probability, probably nothing is required, just reassurance and medical treatment of risk factors. In patients who are at high risk of a pre-test probability of actually having coronary artery disease, you don't want to do a less specific stress test or something. You'd go with something more specific, like either a cardiac MR or a PET scan to try and determine what the extent of damage is. In all other patients with an intermediate pre-test probability, you could come up with that kind of algorithm, where with intermediate pre-test probability and a normal ejection fraction, a stress test, if he's able to exercise, is a good option, and his ECG baseline is normal. Otherwise, you'd have to go with other modalities like a stress echo or a PET or a SPECT scan. Cardiac MRI certainly will help in these situations. The other option is to go for either a calcium score or a conventional CT coronary angiogram. These things would be useful to rule out coronary artery disease rather than to rule in. So you have plenty of guidelines that all these guidelines, by the way, say that these are recommended for patients who, despite optimal therapy, continue to remain symptomatic. And amongst all these, I'll just take you to the next slide. The important ones that you should consider because of their high degree of diagnostic yield are either a CMR, the cardiac MR, or the stress echo or a PET scan. If the patient is on table without any of these pre-test, non-invasive modalities, then certainly use of flow wire, looking at coronary flow reserve, is the diagnosis of choice. So here, to evaluate these patients with stable coronary artery disease on optimal medical treatment with symptoms. So all these three are important. The class 1 indication is certainly to do something like a stress echo or a cardiac MR or a PET scan, and where it's possible, a PET scan is preferred because you can measure myocardial blood flow. All the others are to be performed only if the pre-test probability is intermediate. What are our goals of treatment for these patients, and why is revascularization, if at all, required? 1, certainly prevent death. 2, prevent non-fatal ischemic events. 3, try and slow the progression of disease. And 4, certainly functional limitation and symptom class, to try and alleviate symptoms. So the general approach has gone away from being just a doctor-centric approach where someone came in front of you and you just sat and prescribed him 5 or 6 pills of different categories to try and make him feel better, to a more generalized approach. What's important is to understand his nutritional requirements, the ability to make him exercise optimally, to give him education about why his medicines are important. We see a number of our patients who start off on medications following an acute coronary syndrome. 6 months down the line, they're only on aspirin and plus minus a beta blocker or whatever medicine he feels like taking. It's important that he be educated that some of these medicines are lifelong. To add to that, there is a big patient factor determinant, the social support that he has at home, his literacy about everything and about health in general, cultural factors, spiritual factors, socio-economic, his ability to pay for these medicines. Maybe in this part of the world, we are blessed, we have insurance. But once they go back home, this all becomes in a lot of our countries, it comes out of pocket. So determining that is important. So patient education is important for lifestyle as well as medications, and most decisions should be shared. Cost, invaluable. Right? So there are certain social determinants of health which has now become a mainstay of treatment for these patients, which include all these multiple factors, including the physical environment that they are in, the stresses that they undergo, their literacy rates, their how much they can afford, and the social support that they will receive. Plenty of trials over the years that tell us about optimizing patients, the treatment of such patients. The optimal medical treatment, which is first, along with lifestyle, the treatment of choice, certainly includes event prevention medications like antiplatelet agents, cholesterol-reducing agents, and ACE or ARBs, plus symptom-reducing agents like beta blockers, calcium channel blockers, and other anti-anginal agents. So all these patients with chronic coronary artery disease, unless otherwise specified, to alleviate symptoms, you'd start them on a beta blocker, calcium channel blocker, or long-acting nitrate. You would add the second medication if it is not, if it's not adequate, and then you would add some medications which act at the level of the mitochondria to try and help alleviate symptoms. Why would we revascularize these patients? So there is a few subset of patients where maybe there is a benefit of revascularization. One is low ejection fraction. 2 is very severe stenosis, more than 90% in the proximal portion of these arteries. 3 is multivessel disease, which is proven to be, through FFR or IVUS, to be clinically significant. A large ischemic burden on non-invasive testing like a PET scan or a SPECT scan or a CMR. And certainly persistent angina, but that's the low fifth. This is a busy slide. I've just tried to make it easier here. So patients with chronic coronary disease first optimally manage their medications, continues to have lifestyle-limiting symptoms, consider revascularization in 3 forms. So patients with a very low ejection fraction or left main disease, CABG trumps over angioplasty unless the patient can't undertake a CABG for high-risk reasons. Complex coronary artery disease, triple vessel disease, or left main with triple vessel disease, or proximal LAD with triple vessel disease, and the position and the size of the lesions, it will have to be a heart team approach. In special considerations, where there's single vessel or double vessel disease, if it is proven by IFR or FFR to be significant, you try and treat it with PCI. Certainly, the principles remain the same. So CABG for patients with left main involvement, for patients with diabetes and multivessel disease, and for patients with a high syntax score, it's a little technical, but patients with increasingly complex coronary anatomies. For others, maybe PCI is indicated if guideline-directed medical therapy is not sufficient. So 1 or 2 vessels, proximal LAD involvement, you would certainly discuss it with the surgeon and then decide which of the 2 is best. No proximal LAD involved, more than 90% disease, or less than 90% but IFR, FFR, proven disease, significant disease, you'd opt for PCI. Patients with triple vessel disease with low surgical risk, you would certainly try and optimize their treatment with adding surgery to the armamentarium. Apart from all this, technology is evolving. You have newer generation drug-eluting stents. You have drug-coated balloons, so there's no metal inside your body. You have the use of IVUS FFR to prove the significance of lesions, and these should be now part of our daily armamentarium towards treating these patients. What about follow-up of these patients? Unless there is a change in clinical status, there is no real indication to do non-invasive testing in these patients. If there is change in clinical status, for sure you would do it. Unless the patient has revascularization in the past, in which case you might need to do it more often. Plenty of core components. It's not only medicines. You have to make sure that his lifestyle changes are added to that core component of the medication, and make sure medical compliance is important. What's also important in our understanding of medicines is that we have now anti-inflammatory therapy, we have antiplatelet therapy, which is better than just the aspirin that we had in the past. Lipid lowering to a large extent has helped stabilize these plaques, and the addition of anticoagulant therapy. So this is no more just something that has to, sorry, I'll run through slides because of shortage of time. It is now it's now a complex interaction of multiple things that make us optimize treatment for these patients. Just to go through all these four, the FFR for all these were negative, except for the last one in the bottom, in the proximal portion of the LAD. And the rest of the LAD, actually, the FFR was non-significant, so we could end up leaving most of these without doing any further this thing for this. This is my last slide. So again, just to tell you that integrated processes are important to manage chronic coronary artery disease. You have to have the nutritionist, an educationist, you have to have the presence of a physical therapy. Gentlemen, you have to educate the patient that it's not only about lifestyle, it's also about adherence to medications that would help him continue to remain in CCS and not become an ACS, and will help increase longevity. Thank you, sir.
Excellent, thank you very much. Right, Mohammed Andron. So randomized clinical trial tell us efficacy and safety of anything. Otherwise, we just keep dreaming and saying this is good or bad, which is happening in this part of the world most of the time. People talk about their experience, but I think randomized clinical trial is keep us on track. So ischemia trial and the others showed no mortality benefit in symptoms. Then we have Orbita 1 came, Orbita 2. Orbita 1 showed that medication does the job, just improve the angina, and PCI add little. Then Orbita 2 came and showed those who are not taking anti-angina intervention, it's expensive anti-ischemic medication. So you as an intervention cardiologist, and you heard from Jeremy's very aggressive intervention as well, both of you. So how you manage? Your business will be out. What do you tell me? How you practice?
Yeah, thank you, Jerome, and thank you, Prof. Shahab. I think it's, I mean, these studies and basically, I think I think the population is different from our population, and in Courage study, for example, which is the first trial for medical therapy versus coronary intervention, they recruited like 3,000 patients after they excluded maybe around 20,000 patients to recruit 3,000 patients. And I remember in 2007, Bowden, who is the main trial investigator in this study, he came to the UK and presented some of the cases in the study. And he claimed that these cases, some of them have proximal LAD. And in the audience, they were all cardiologists, intervention and non-invasive. And he showed a few cases, proximal LAD 90%, and he said these were included in the study. And all the people there, they said that we will not randomize these patients because they have severe proximal LAD. But he claimed about a third of his patients have LAD, proximal LAD disease. So yeah, but don't forget the average age of those patients like 70 years old.
Absolutely.
The population we see is younger. I mean,
40.
Our average population like 50. So I saw 45 years old in the clinic last week. He wants to play sport. He's very athletic, and he's having angina. So would I say to him medical therapy? I don't think so. But I think at least he needs an angiogram to check the status and the anatomy, because I think for me the anatomy is important. If he has a distal disease and CTO in distal right, I would probably most likely leave him alone for medical therapy. I agree with all of this. But if he has severe proximal LAD, 90% focal lesion, and he wants to play football and sport, and if this was my artery or my relative's artery, I would say, definitely, doctor, if you can do PCI with good job and no risk, then do it. I don't want to take medication for life. Do you agree? Yeah. But if I have 70 years old who has multivessel disease, moderate, so of course I don't want to put like 10 stents to make him feel a little better. So that's the judgment. And all of these studies, unfortunately, occurred in the USA, where they have a very bad practice of over-stenting, over-treating, and stenting like 40% stenosis, all of these, So all of these studies like FFR and the courage studies and so on. But we know those patients will not benefit. So if you have a 70 years old male who's been having stable angina for 10 years and very stable, so do actually I believe that if I stent him, I will make him live longer? No, I don't think so, because 10 years is stable. But if I have 45 years old who's been having angina for the last, say, 6 months crescendo, and he cannot do exercise now because of the chest pain, I think that patient, I would definitely at least do angiogram for him.
Absolutely, sir. And I think, with the advent of things like FFR, now it makes our life much, much better. A lot of those courage patients probably didn't require anything when they were intervened. So we don't know that.
Okay, as I said, the courage and the schema trial is still what you said. But then we had Orbiter 1, Orbiter 2 told us exactly what the PCI does. PCI relieves symptoms, not improve the mortality. If you use it without medication, symptoms. The same with Orbiter 1. So basically, I think we have to be careful. I think this is make us to, choose the right, diagnosis, I agree with you. You can do it with CT scan. You don't need to go for coronary angio, because once you go for coronary angio, your hands become itchy. You have to do something. Do the CT, get the diagnosis, then sit with, look, you want symptom relief or you want mortality relief? I want symptom relief. Okay, I can do it with you with medication, and I can do it with you with a PCI. Which one you prefer? Both evidence available. You can do that, because if you do the PCI, Dr. Mohammed, some people do it Mickey Mouse. They don't do imaging, intracoronary imaging, not there. They just put a stent, go.
My inquiry for Dr. Andron. Dr. Andron, I do believe in evidence-based, okay? And you already spoke about anatomy. But anatomy alone without physiology is not an evidence-based, because we sometimes have some anatomical stenosis with no ischemia, and it happened. Of course, it is not 95%, but we still have 70% coronary stenosis, and the physiology is good. There is no perfusion effect because of collateral and many other things. That's why we have to stick to the evidence-based, not only anatomy.
Those stable without ischemia, of course you will not treat them. We're not talking about it. We're talking about if you have, like in the orbit, orbit has some limitations, and the majority of single vessel disease, very stable angina, extremely stable angina. And prove actually that PCI is very effective in reducing angina without medication. So yeah, of course, it's a little bit expensive, but again, the medicine are expensive. But if you have a flow limiting lesion in the proximal LAD, I think that would no doubt give you survival benefit, in my opinion.
Okay, let me give you the bad news now. Orbiter 2, after they did everything for this, cleaned everything, revascularized everything, 59 remains symptomatic. So they open everything. So the answer is not opening everything. There is microcirculation issues as well. Maybe the work you did is not good. There are many reasons. So we have to be humble. I think we have to, this evidence make us more humble. No, Anna, the answer is this, open this. No, it's not anymore. Any other questions? Great job. Thank you very much.
Thank you very much, sir.
We'll move to next speaker. Next speaker. I was on yesterday. A coronary intervention nightmare in cath lab. Allah ya'in. Dr. Paul, please share. Why say it nightmare? There's no daymare? As always nightmare? Yes. Night. Okay.
Good afternoon, Dr. Shab, organizing Dr. Abdul Munir. The topic, because it's called a nightmare, because I didn't sleep for 2 days. So 2 nights. So that is the main reason that it became a nightmare. I had, as Dr. Jairam mentioned, from an aggressive cardiologist, he is now more into FFRs and becoming less aggressive. I thought I may become more aggressive. So that may be the reason why I had a nightmare. So this is a 64-year-old male, hypertensive and hyperlipidemic for last 2-3 years. He's non-diabetic. His HbA1c was 5.5%. And he had a recent new onset of angina, so it was not a chronic stable angina. And his first troponin done by the GP was 13.2. And he came to my OPD and a very 50 kilo thin person. So I stressed him, though it was a new onset of angina, just I myself was there. So, and an echo was also done, that was normal, no wall motion. And so since stress test was very strongly positive, and the basic ECG was a sinus rhythm, no any ischemia changes, PR interval is normal, QRS, no good progression of R waves. So the treadmill was 3 minutes, and he had angina, 5 minutes positive. There was sort of LBB-like of formation, but there was no hypotension. Heart rate was also achieved around 134 beats per minute, and it was 85% of the age-predicted heart rate. So I did an angiogram. So angiogram was clearly showing a tight proximal LAD lesion, and also a diagonal was also impinged with a slow flow into the first diagonal. So, and also there was lesion in the circumflex that 90% OM, and distal circumflex after the OM was totally occluded. So the right coronary was huge, dilated, and it was not having much significant disease except for the PDA had some disease. So this was angiogram, that is proximal LAD, 95% block, first diagonal, 99% to subtotal. Diagonal had a moderate disease, and left circumflex was 90% diffuse block with diffuse distal left circumflex was 100% block. RCA had a moderate disease in the PDA. So this was angioplasty which I did, pre-dilated with a 2 mm balloon for the LAD, 2.75 into 38 mm drug-eluting stent was deployed, and post-dilated with a 3 mm balloon to 14 to 16 atmospheres. And the diagonal, which was dilated with a 1.5 mm balloon, to increase to a 2 mm balloon up to 6 atmosphere. And left circumflex, I dilated with a 2 mm balloon, and a drug-eluting stent was not placed. It was a DCB, 2.25 into 25 mm drug-eluting balloon up to 10 atmosphere. The wire I used was a BMW wire for the LAD, but diagonal was not able to cross with the BMW wire, so I had to use a stiffer wire, which is a hydrophilic pilot wire. So I didn't have any complication immediate or even after post-operative. So this was a balloon angioplasty and the pre-dilatation, then the deployment of the stent. And post-dilatation of the LAD stent. And this is the final results. And also I did pre-dilatation of the OM branch, and a drug-eluting balloon was deployed. And this was the final result. So the proximal LAD, mid LAD, there was no other issues. And the diagonal as well as the OM was flowing. So no complications, nothing. Patient didn't have any chest pain, and he was shifted out of the cath lab. And just 1.5 hours later, it was a radial procedure. So patient developed bradycardia and hypotension. So the pulse was 54 per minute, and blood pressure dropped to 72 by 41 millimeters of mercury. ECG done at that time, it was sent to me by WhatsApp nowadays because I was just at home. So it didn't show any STT changes. The initial presentation when the ICU doctor told me was like a vasovagal. So I also thought so, it was vasovagal, no chest pain, no ST elevation in the ECG. So IV atropine and IV fluid challenge was given, and patient improved within 20 to 30 minutes, and no chest pain. But within 1 hour, they called me again that patient has developed a recurrent episode of hypotension with mild tachycardia. And this was ECG at the time of hypotension with tachycardia. So this was the ECG, and there was no severe sinus tachycardia or anything, but definitely suspicion was a pericardial tamponade or a large developing effusion. So this was echo done at bedside. So it showed a circumferential fluid all around the heart with severe diastolic collapse. And patient was definitely, the treatment which continued, heparin was reversed and supportive care continued. IV fluids were increased and multidisciplinary care team was involved. Cross-matched blood was arranged. Patient was tolerating without an intubation, but so I shifted him to cath lab and immediately did a pericardiocentesis. So during the echo, I could see very well the patient was improving with the pericardiocentesis, and good hemodynamics also improved. And I did an angiogram after the pericardiocentesis, and it was around 700 ml of blood was taken, and it was auto-transfused back into the right femoral vein. And the angiogram, as such, didn't see any flow anywhere. Where was a rupture? I'm not able to see. So I carefully saw every angle, but in that night, I was not very much looking into, but as such, there was no staining or anything. So I thought maybe some small tear or not a perforation, small perforation or wire perforation or something. So I thought with the pericardiocentesis, it may settle. And since I reversed. So the pericardiocentesis was standard subcostal route, and 700 ml of blood was aspirated and auto-transfused back to right femoral vein. And pigtail catheter was kept in situ, and patient was shifted back to ICU. 2 hours later, severe hypotension, 60 by 40 millimeters of mercury, mild improvement with IV fluids and dopamine. And then I told I will to intubate the patient. And echo was showing severe pericardial effusion, and 500 ml of fluid was again taken and auto-transfused back. Discussed with the cardiac surgeon, the angio films was sent to them in video format to plan whether anything we are missing, because surgical intervention was the only option. At that time, I thought so. Since there was no obvious leaks which was seen in the angiogram, that plan was initially abandoned, and then anyway, and repeat angiogram was done. So removal of fluid and repeat angio was done, and it was showing like this, but carefully when I was seeing, there was a small staining over there. So we can see that there is a tip of the wire perforation there, and that is causing the fluid into the pericardium. And whenever the pressure in intracardiac pressure is increasing, automatically it seals, and then when the patient goes into hypotension, it's again happening. So that's what is happening that time. So anyway, since this was a perforation of my heart, of course, the only option was to plan closure. So instead of coils, we thought of putting a covered stent across the LAD, where the diagonal was getting the leak into the pericardium. So a covered stent was placed and was post-dilated, and once the covered stent was put, we checked the right side also, and the flow was well maintained. So a covered stent of 2.5 into 19 millimeters was deployed across the LAD and septal, and the post-dilatation was done with a 2.75 into 12 millimeter at 16 atmosphere. Once this was done, everything got into a silence. Patient also improved, though he was intubated. There was no pericardial fluid accumulation again. We waited in the cath lab for 1 hour and just make sure that there is no fluid accumulating. And myocardial contractility was well preserved, no further accumulation, nothing. So after the covered stent deployment, everything stabilized, hemodynamics as well as patient's condition. He was extubated in 24 hours. Pigtail catheter was removed in 24 hours, and a repeat echo did also no pericardial effuse. He was discharged on the 3rd day. So the pre-procedural and the post-procedural labs, 13.7 was the hemoglobin. It dropped initially to 12 and then finally settled at around 12.3 grams. He was having lactic acidosis of 7.15 millimoles. It improved to 2.1. Creatinine, which was baseline, was 113, worsened to 130, and then stabilized at 97. All the electrolytes were normal. And 6 months later, the patient comes, we did an echo, there was no wall motion abnormality, no pulmonary hypertension, ejection fraction is above 60. ECG, this is ECG after 6 months, R waves are all preserved. T inversion is developed between V4 to V6 and 1 and AVL. Otherwise, patient is doing fine, there's no other issue. So the complication which has happened is a wire-induced perforation, which is a complication which happens when you do with high aggressive intervention. So little discussion about the incidence and predictors of coronary perforation. It's a fatal complication which has an incidence of around 0.1 to 0.6%. Especially the perforation occurs when the dissection of the intimal tear completely penetrates the arterial wall, leading on to the vessel rupture with minimal dye staining. And the reasons are basically the advanced stage, female sex, renal impairment or non-STEMI. Other angiographic factors are coronary calcification, tortuous vessels, as well as left circumflex and right coronaries have a higher incidence of perforation, and eccentric lesions. The other factors include use of hydrophilic wires, extra stiff wires, and atherectomy devices. In my patient, basically there was coronary calcification was there, tortuosity was there, and there was usage of hydrophilic wires. So these are the three main reasons which we could see in my patient. Incidence is 0.1 to 0.3%. Mortality is around 7 to 17%. And use of stiff or hydrophilic wires, cutting balloons and rotablators, usage which has been increased, can cause this complication incidence. In this patient, actually, I couldn't see an initial myocardial blush or a contrast staining, so which I could have missed, or I'm not sure. So what way we can prevent this complication, that is what I want any more suggestions. And perforations, as I mentioned, is due to distal migration of the wire, and hydrophilic wires are very, very notorious for causing this, and even stiffer wires, but this is a pilot FC wire, not very stiff, and the mechanism is because of the distal migration. And the different types of perforation, that is type 1, which is just a extraluminal crater formation without an extravasation. Type 2 is with myocardial blush, and type 3 is the big one, with contrast streaming and cavity spilling. So the management, the conventional management is the prolonged balloon inflation, reversal with anticoagulation like protamine, and we can use platelet transfusion if the patient is on apixaban. And pericardosynthesis is the life-saving measure, definitely, because for cardiac tamponade there is nothing else we can do. And the prolonged balloon inflation was being done before, and usage of covered stent, that is what I used, because that has revolutionized the management of coronary perforation, specifically those perforation occurring in the large epicardial arteries. And surgical role, definitely, because if there is a requirement, that's the best way. The surgeon has to be involved, and the treatment should be given to prevent any complications of death. So some novel perforation sealing techniques have been seen in the literature. So coils, as usually they've been used. Then the injection of thrombin. They've been using cut pieces of floppy wires and pushing into the perforation. And there's a stent sandwich, that like a balloon which has been cut the distal and the proximal, and that's used as a covered stent they are using. And some Japanese have been used umbrella technique, where a cut piece of a balloon was mounted on another balloon, and they have sealed the perforation. So these are the usages which can be done when there is no covered stent available. But definitely we always keep a covered stent for us, because it is a savior at many times. So to conclude, management of coronary perforation requires early detection and angiographic classification. Caution should be needed while advancing guide wires and dilating the coronary artery lesion with a pre-stenting or post-stenting. And immediate sealing of ruptured coronary vessels using a covered stent with a reversal of apparent anticoagulation and relief of hemodynamic compromise by like pericardosynthesis. And usage of covered stents in proximal large perforations does not need any additional skills for the interventionalist. And the most important thing is don't get into a panic button, because when you see pericardiac tamponade, it creates a lot of panic. So involve the cardiologist, cardiac surgeon, anesthetist, and act fast. Thank you.
Excellent. Thank you very much. Right. I think the take-home message from this, I think it's very technical. So having heterogeneous of participants here, not interventionists, for you to take home messages. We, as an intervention, we sit, discuss with the patient before we do procedure the complication list, because, so bleeding is very common, up to 20%. So we have to mention that something happened to their hands or their legs. Then access problems. Then we talk about coronary perforation, which has happened here, or dissection. It's, as he said, in 1,000 we treat, one of them will get that. In a good hand like him, good hand. But in a bad hand, of course, much commoner than that. Then, of course, death could happen. Myocardial infarction, again, should be there. Stroke could be there. Radiation, allergies, there are many things could happen to the patient. So it's without, we should mention all this before we go, and then you say, oh, you didn't tell me, you will end up in the court. So as a physician, don't forget to do that. So going back to your case, so this was a CCS case, no? Because troponin normal, صح?
Troponin normal, but it was a new onset angina. He never had any angina in the past. So it was going to a NSTEMI.
Yeah, we don't have a second troponin to know if it's acute coronary.
Yeah, I had one. It was a 28 or so. After all this complication.
Definitely.
Yeah.
So, Dr. Mohammed Andron. Nightmare, huh? Daymare? Nightmare.
Yeah, so let's just agree that there was indication for intervention. I think there was indication. Because this is not stable angina. This is different. So this is actually unstable or crescendo angina. So definitely indication for intervention. For at least, I think, for investigation beyond maybe you would start him on medical therapy first, but treadmill test was strongly positive. Yeah, I think, coronary angiography is indicated, I would say.
Yeah.
How early, how soon, I don't know. I mean, in Europe, maybe this patient would have been started on medical therapy if his troponin is negative, and then seen in the clinic like 2-3 weeks later and reassess his symptoms. But I think here we tend to intervene early. I wouldn't say they are doing the right thing, but there because of the cost issues. I mean, in the UK, for example, we used to wait for like few months before the patient seen again in the clinic, such patients. But I think that approach is good. So first of all, I think indication, yes. Now, this is unusual complication, is uncommon complication, but it is, of course, recognized complication, especially in the diagonal. I mean, diagonal is notorious for perforation, which does not heal on its own, because the diagonal supplies the lateral wall of the heart, which doesn't have much of the fat. I think maybe the cardiac surgeon would explain this. So the perforation in diagonal commonly leads into tamponade, which in significant proportion needs further intervention beyond the pericardiocentesis. In the majority of the perforations, you put pericardiocentesis, the patient does not re-bleed again. But in the diagonal, it's more common to actually require further treatment. So I think you did the right thing. And then the treatment is just, of course, variable. So you can either put covered stent to occlude that bleeding branch, or with this diagonal, maybe I think I would have maybe started with maybe embolization, with coil, or with fat embolization, and so on, if I can see the bleeding vessel. If I cannot see it, I think safest is just to put a stent graft across the bleeding vessel. But that diagonal was actually large, and interestingly, did not occlude after you put the covered stent, correct? Is that my...
Yeah.
Yeah, so maybe because the covered stent was not large enough. So there is a gap
between... Can we get the angio back? I want you to go back to the angio, which you finished after doing the PCI.
Yeah, if you go back
go back to that. We want to learn, from this for our future fellows or cardiologists who does, these complex cases is to,
So because normally, if you go back to that.
Anyway, until we go back. So this patient is strongly positive TMT.
Yeah.
You suppose not with you, somebody with another cardiologist. What do you advise them to do? To load medication?
Yeah, they will
Wait.
start him on medical therapy.
We're not in a hurry. Patient is still stable. You can load the patient with medication.
So top one is negative, so you don't have to panic. You start them on aspirin, statin, and beta blockers most likely. Yeah, you have to prepare the case, and then commonly you would say that you would see the patient again after like 2-3 weeks to reassess symptoms. I think that's very reasonable.
So the guidelines. The reason why I ask you this question because the guidelines says don't load the patient with
aspirin. No, aspirin.
Only aspirin. No, I'm saying you're doing this, but are we all doing this? Are you guys, when you see a patient going for, you want to take him for PCI, will you load them with everything or just aspirin? How many load with everything? Come on, be honest. You will not load them with ticagrelor or Plavix and aspirin? And I know you're interventionists, but I'm talking to the rest. We do that, huh? Come on, we do that. But guidelines say different. Okay, but what else? You got it. So teach us. You finish the intervention. Show us after they finish the intervention. You done that. You done that. Okay, next. So you showed us nicely. There's nothing there. I mean, how can you predict this? Very difficult.
There was later on. I saw there was a
later on you saw.
small very thing after all this processing done.
But that's
But
did you treat the very first diagonal, the very small one?
that diagonal was open.
Yeah, it's very small actually, that diagonal. The first one. The second one is big, yes, but the first one is small. And that's the bleeding came from.
Yeah, the second one I didn't treat that. I didn't touch. The totally occurred I opened.
Just a few, maybe, okay.
So you put a stent on that one, or you just a DCB?
Just
No, that
balloon.
was no DCB there. There was
Balloon
only a balloon only I did.
Okay, so
The DCB was for the OM.
So this one.
okay. So you left it like that, okay.
And then now covered
So
stent
then
on
it
that
flowed.
one.
Yeah, but it's maybe the wire is too much deep inside.
Yeah,
Small.
wire little bit went
yeah.
to the periphery and came out.
Yeah.
That's why.
No, we all do this. I'm not critiquing it, but just for future, somebody not to, it's too much inside. And it's hydrophilic. Tfadal, Doctor. This one.
Thank you, Dr. Bowell. Just asking about that, do you have any data about the incidence of perforation for the case of directed stenting versus multiple pre-dilatation? Because I see in this case you did multiple pre-dilatation.
To the LAD, only one pre-dilatation, one stent, one post-dilatation. For the diagonal, 1.5 millimeter, one dilatation, and increased to 2 millimeter, one balloon. So two dilatations.
Yeah. So I think the question is, the whole idea is just to keep an eye on end of your wire.
Wire, yeah.
That's it. It's not regardless of how many, that's nothing to do with the end of the wire. Make sure it's not kinked or it's too deep. So and use the right doctor. Yeah.
Thank you, Dr. Paul. So that was a real nightmare.
Yeah.
So I'm just wondering about the antithrombotic treatment. Since we already reversed it, due to the catastrophe, we reversed it, the heparin with protamine sulfate.
Protamine was given.
So after the procedure and after everything is settled down and the patient is stable, what do you do regarding the antithrombotic? Will you just go naturally as if there's nothing happened? The cover is stented there. The patient is protected. You just you sealed the perf and everything was fine. Would you continue the same antithrombotic?
No antithrombotic was given for 24 hours. I just continued antiplatelets both, aspirin and clopidogrel.
Okay. Same timing. You didn't delay anything. You just continued the aspirin and clopidogrel the same day.
Yeah.
Perfect. Thank you.
Yeah, I think that's very brave. I don't know. If you put how many stents you there? 2 stents.
One stent.
One stent. Okay. Yeah. What do you think the risk of, Dr. Mohammed? Risk of stent thrombosis.
Yeah, so you cannot, of course, I think...
what do you think the risk will be? 100%? 20%?
If you stop antiplatelets?
Yes.
No, not 100%. It would be like maybe 10%. But I would not stop
so it's not 100. Don't worry. Nothing happened to this patient. Okay.
I would not stop the antiplatelets. No, of course you would continue.
Antiplatelets I didn't stop it.
But maybe if you give Clexane or heparin, you would not give it.
One day I didn't give. Next day basically.
You would give, But I think the only thing is caveat is the stent. I think the risk can be reduced of the stent thrombosis by further post-dilatation and so on. But that's for another discussion. But that diagonal is actually small, so you can easily take the decision to say I'm not going to put to go into it and then embolize it and so on. So the easiest approach is actually to cover a stent across it and close it. It's less than 2 millimeter vessel.
Exactly.
So just bye-bye, let's go, finish.
Exactly, yes.
I agree.
If the same thing had happened to the second diagonal, what would have happened then? The second diagonal was really big. And if there was a
Second
problem
diagonal is big.
there,
Second diagonal is big. Then the second diagonal, if you have perforation in that second
What have you
diagonal,
done?
you would go with.
so then I would have certainly tried to coil that second diagonal, sir, because
MashaAllah. Great. Thank you.
Thank you.
Done the job. Okay, thank you very much. So we go for another complications maybe now. Vascular access and cardiac catheterization. Dr. Maher. Dr. Rahman Maher. حياك. Vascular surgeon.
Assalamu alaikum. Thank you, Mr. Chairperson. Not sure how to use this. My name is Abdurrahman Maher. I am a vascular surgeon at Mediclinic Airport Road. We'll go to that. I'm very privileged by a cardiologist inviting me to give a talk to a very smart cohort of people. So I'm going to try and learn more than educate here. This is a famous saying for Al-Mutanabbi. For those who don't read or speak Arabic and not willing to learn, it describes how he had so many insults to his heart that it's now a bag full of metal, to the degree that when he's hit by any new spears, it's breaking metal over metal. What I'm trying to say is that we're doing more than ever coronary interventions, and we're more so to need redo procedures, which brings us to the question of access. So as I said, I will try and learn from the masters, as I learned endovascular procedures at Prince Alfred in Sydney, and my mentors learned that from cardiologists. You guys are the pioneers of endovascular procedures, of course. We access arteries and veins for cardiac catheterization, whether it's right side or coronaries. And for peripheral vascular disease, we have accessed every named artery in the body. And for the veins, we have accessed most, if not all, the major veins for various indications. Now, question number one for the respected audience. Which is your preferred access for coronary intervention? Radial artery versus femoral artery. So can you have your hands up for radial artery? Femoral? And hands down for what? So which one is easier, technically easier? Is it radial? Yes. And which one is safer for the patient? Radial. So you are right, it's now, the evidence is out there and it's established that the femoral access is associated with much more complications than radial access. And most of your guidelines suggest that radial access is the gold standard access for coronary interventions unless there is a reason to avoid it. Question number two about radial access. When you do radial access, how many of you do Allen's test and check ulnar pulse before accessing radial artery? Hands up. No one is looking, okay. How many uses routine ultrasound access for radial artery? We'll come to management of post-operative occlusion of radial artery in a minute. So this is Allen's test. If you're not familiar with it, it's very useful to give you an idea of the circulation and perfusion of the hand. You're almost always using right hand access, the dominant hand, so it is important to make sure patients are safe. Your cohort of patients, as Dr. Andron said, are younger, relatively healthier generations, but when you come to older people, smokers who have diabetes and renal impairment, you have higher prevalence of incomplete vascular arch in the hand. So Allen's test is a good maneuver where you completely occlude arteries, radial and ulnar, ask the patient to squeeze their fist, and then open their hands, and then gradually you can release one artery after the other to see if ulnar artery alone is perfusing the whole hand, or do you have a segmental perfusion to the hand. Having said that, these are the complications of recorded complications of radial artery. Radial artery occlusion is probably 5 to 10% of patients we see. It is the most common one. You can teach me more about radial artery spasm. You would see this at the start or the end of the procedure, and you have your routine bailout to avoid this. Have you ever seen a hand ischemia after radial artery access? Hands up. I have not, but I've heard of it. So checking the ulnar artery is very important, even though it is most likely the hand-dominant artery, but checking it, especially in diabetics who can have arch interruption, is very important practice. So radial artery occlusion, as I said, is a prevalent thing after radial artery access. The cardiologists don't seem to care much about the hand. They care about further intervention. So I have seen some cardiologists who anticoagulate with therapeutic Lexan for a month to treat radial artery occlusion. But most of these are subclinical occlusions. Do you routinely treat radial artery occlusion if it is asymptomatic? Hands up. Do you check for radial artery occlusions routinely? No. Some of these factors are relevant to prevalence of radial artery occlusion post-intervention. In terms of managing hand, unless the hand is symptomatic, which is exceptionally rare after radial artery access, most practitioners would not treat it. I have seen reports from cardiologists who uses the same radial artery via distal approach and a further intervention, recanalize the occlusion and access the heart. Have you done that before?
That would make your procedure a lot more difficult. So you're already going to have a complex procedure. You don't want to start with a huge complexity because you have alternative access. So I don't agree with this.
The next question, transradial artery, the classic conventional axis versus the distal radial axis. The anatomical snuff box axis is gaining popularity over the world. Which one of you have used the distal artery axis? Hands up.
Just once for just show off.
Do you then use ultrasound guidance for this axis? So there have been few trials. The disco-radial trial showed no difference in bleeding, false aneurysm, or ischemia events comparing the two radial axes. However, Tendera trial has shown some benefit in the distal radial artery axis in terms of bleeding. The Ratatouille, if I'm saying it right, trial showed no hand impairment after distal radial artery. The QUADRA registry have registered over 5,000 cases of distal radial artery, and it seems to be the more popular future axis for coronary interventions. Do you agree with that? Distal radial artery is getting more and more used. Do you think it will pick up and be the routine or the classic one?
It's maybe in the media, but it's not true. It's not happening.
So for those who are interested in using it, it is advisable to use ultrasound guidance to avoid tendon injury and functional hand problems. Femoral access. Even though it is not the classic and not the gold standard, often cardiologists will elect to use femoral access for complex procedure, absent radial arteries, or TAVI and similar procedures. So question number 4, do you check foot pulses before you do a femoral puncture? Hands up. Do you routinely use ultrasound-guided puncture for femoral artery? Do you routinely use closure device for the femoral artery? Do you at all use femoral artery? So as we mentioned, femoral artery access is associated with slightly higher, probably double the radial artery complication. Most of those are false aneurysms and rarely AV fistula. The universal randomized controlled trial has shown no difference actually in rate of complication when using ultrasound-guided femoral puncture. However, the selection of patients and the techniques and the lack of using closure device in this trial have been criticized. The SURF trial, another randomized controlled trial where usage of routine ultrasound and closure device was shown to be better in terms of outcome, less complications, and less pressure and control time compared to manual compression of the axis. So what's my take as a surgeon? I do use ultrasound guidance routinely for the femoral puncture to make sure we get in the right zone of the femoral artery and to examine and avoid any plaque in the wall. It is a very easy device to have. There's no excuse of not learning the device and catching up with the technology. And it is for patient safety. Even though the evidence has not backed this up yet, it might be difficult to have the evidence, but in our clinical day-to-day practice, there is a lot to learn from ultrasound. It is not advisable to avoid using ultrasound in radial and femoral artery until you need it in a difficult case. Then you don't have the skills and the techniques and the tips for using it when you need it. Ulnar artery. I got this image from a cardiology paper, and I love it. And then I saw a cardiology colleague from Australia who's trying to publish 20 cases where he has done that. Would you ever consider doing this for coronary complex intervention?
Yesterday I did ulnar, yes. I do ulnar most of the time.
Both of them?
Not both, no, one.
So while there has been some small series published that it is safe to access the ulnar artery, and they have very, very small number of, or zero number in these series, we're talking 10 to 20 cases max of hand ischemia. I would strongly, as a vascular surgeon, advise against it, simply because I don't have a bailout from that. If we have hand ischemia at this level, there will be no bailout and it will be catastrophic, no matter how rare it might be. I don't think it's a simple one to fix. I'd rather deal with a femoral artery bleeding all the time and not deal with one distal ulnar artery occlusion. Ulnar artery is different. Ulnar artery is similar to pulmonary arteries. They're very fragile, very sensitive. And once you lose the palmar arch, it becomes a nightmare. And the consequence, unless absolutely necessary, I'd rather you go to any other artery than the ulnar artery. But this is the vascular view. Who am I to tell you? Brachial artery access, would you do it? Hands up. So brachial artery is an end artery at the end of the day, so you don't want to have complications with it. The complications of brachial artery documented are double the number of complications in femoral artery. So if you must go to brachial, there's another anatomical consideration, which is the brachial artery is very mobile in the mid-arm. You cannot control it percutaneously. You will almost always have a hematoma. If you go distally where it's in front of the bone, it's very adjacent to the median nerve, and it's under the bicipital aponeurosis in a very tight space. Even a couple of drops of blood will cause median neuralgia and chronic hand pain and a very unhappy customer. So if you must get to brachial artery, I would recommend a small cut down and proper repair at the end of the procedure. Other axis is the axillary subclavian artery axis have been described and used for TAVI and other procedures. Even though you can use percutaneous closure, but the proximity to brachial plexus would suggest an open, small cut down, if you must, is a better option. Transcaval axis for TAVI has been described, and we've been discussing this with Dr. Andron. Venous access for right heart catheter is another topic to discuss later. What is my message to my colleagues from this? I think we need to early adopt the technology, and by that I'm talking ultrasound and closure device, and get used to it and train our team so when we need it, we know what to do with it. I think an MDT approach to difficult access is priceless, and it's much easier to plan access with your colleagues than having to deal with a complication of an access later. And I think thinking of an exit strategy, like the case of ulnar artery access, is very important. Thank you very much.
Excellent. Thank you very much, Dr. Maher. Great, discussion. I think this is, as I said at the beginning, access complications, because now we are dealing with structural, we're dealing with, hemodynamic support, impella using. There are many reasons for us to think about access complications. But of course, the day-to-day what we do with the radial and ulnar is, is there, but it's very, very minimal. Allen test, I think, we used to use, I think me and Ron used to do it, but not anymore because there's no evidence is predict you anything in the future. It just, for legal point of view, you have to do it. Just you have to mention it in the notes. But really, there's no evidence to suggest that. But any comments from you guys?
Thank you, Dr. Abdurrahman. It's a very nice presentation. I think just a few things. So the distal radial artery, I cannot see personally any advantages over using the standard radial artery. The ulnar access, I agree with you. I think should not be used unless you have absolutely no other access. And the few cases I've used it, you have hematoma because difficult to compress. It's actually, and plus hand ischemia, of course. But it's not compressible as the radial artery, and that's second. And third thing, I think the use of ultrasound in the femoral access is mandatory in my view. I would love to make it mandatory in my cath lab, because it's definitely the major factor to reduce your, and I think it should be in the KPI to reduce your vascular access complication is absolutely very, very important. And I think all of us, you use now radial access, so we become less efficient in femoral access. I intentionally tend to do, every few cases, tend to do some femoral cases just to keep the skills and do the ultrasound and the closure device and so on. But because, as the Dr. Abdullah said, we don't use the femoral now commonly unless if you have complexity or TAVI or other procedures. Thank you.
Any of you seen access complication coming to you, complaining of the intervention cardiologist? يلا طلعوا فضايحنا.
Thank you very much for this nice presentation. Actually, in my practice, the most common complications I have met is chronic radial artery occlusion, number one. Number two, radial artery thrombosis with manifestations of thrombosis, swelling, pain, redness, and etc. I think nothing to do for chronic obstruction or chronic occlusion, but for post-intervention thrombosis, if there is indications for anticoagulation for some period, especially for long-standing intervention procedures or complex procedures or etc.
There has been studies and case reports looking into anticoagulation for 1 month, and others looking at heparin 2,500 versus 5,000 at the end of the procedure. Others have looked into occluding the ulnar artery for 20 minutes to force more flow through the stenotic or the vasospastic radial artery. There has been no evidence to suggest any of that has advantage over expectant management. So for thrombosis, if there is no hand ischemia, I would not advocate to recanalize. I would leave it. And anticoagulation does not have enough benefit to suggest taking the risk of anticoagulation together with the antiplatelets they're usually on. However, if the symptoms is pain and swelling from the thrombus itself, then an anti-inflammatory and topical pain relief, almost 100% treat those patients within 4 to 6 weeks. All what they need at the beginning is reassurance that it's a transient inflammatory process and will go away. And then in 4 to 6 weeks. Some of them will recanalize, but most of them will have chronic occlusion, and I would treat all of these conservatively.
Even if ultrasound shows thrombotic occlusion at
Yes.
some part of the radial artery?
Yes, because the benefit is not there. While the risk of trashing the hand from recanalizing a radial artery full of thrombus is real. So you might end up with gangrenous fingers, tips, and things like that.
Because really, I met two patients with radial thrombosis and occlusion after PCI. What I did, I give him oral anticoagulant for 1-2 months with complete revascularization and disappearance of symptoms, swelling, redness, and etc. And
so in absence...
do you think that there is no need for anticoagulation even if there is thrombus
As my colleague said, in absence of evidence, then you go case by case. Case by case, you ask yourself, why did it thrombose? If it's a traumatic dissection of the radial artery, then anticoagulation is not likely to help you. If it's an old, diseased, calcified radial artery, anticoagulation is not going to help you. But if it's a young patient that has vasospasm of some sort and superimposed thrombus, maybe you could argue that anticoagulation is safe for this patient and a trial would not hurt.
No, I think it's this is really important because I get patients referred to me, doctor, we are concerned the radial artery is occluded, and they explain to the patient that your radial artery now is occluded, you have to do something. And the radiologist, I have a few cases, the radiologist told the patient that your radial artery is occluded. So it's common 5 to 10% in the trials. In Liverpool, we did, I remember they did trial, I think maybe you mentioned the trial, is about 10,000 patients because a huge number of patients. The occlusion rate was between 5 to 7% and absolutely no effect whatsoever, and treatment is not required in all cases. Not even in a single case. And I now what I do now, if the GP told me the patient is having radial or arm pain, so we want to do ultrasound, I tell them don't do ultrasound because absolutely no need to do ultrasound whatsoever. I think it's only one case.
Dr. Andron, do the ultrasound and refer to vascular. We need the business. We will reassure the patient for you.
The issue, Abdurrahman, is the patient get panic. If you tell the patient, oh, your radial artery is occluded, the patient just get mad. Absolutely, they think this is something serious. So what we tell them is absolutely don't worry about it. There's nothing. Even I don't even mention it. So that's why I think we should not do ultrasound for those patients. Any like little of arm pain, do ultrasound. Of course, you would find the radial artery occluded because you could not feel it. But has any consequences? No, it doesn't have any. The only consequences we have is the re-intervention on that side is going to be diminished or compromised. That's the only risk in my opinion. And in the studies, there's no hand ischemia whatsoever. And giving anticoagulation, again, is not going to help.
I think this issue will never end. I know. So the access complication, if you look at what is published, from 1% to 30%. Yeah? So that means there's also variation, many reasons, characteristics of the patients. But if the patient has not got persistent problem, then ignore it. As Dr. Mohammed Andron, don't do it because we know asymptomatic. We know the occlusion happens. But as long as I had a court for myself or cases, but alhamdulillah, I won it because it's common. I say, as long as your evidence base is fine. Patients try to look for these excuses, goes to different, get opinion. You want to say something, Dr. Paul?
I had a complicated case around 5 years back. A patient came with, she's a 65-year-old lady, actually a mother of our own staff, with an anterior MI. And that time I did a femoral angiogram and angioplasty, primary. And after he had an hematoma and developed a AV fistula. Later on with compression, everything settled. 6 or 5 years later, she developed an inferior MI, but this time it was stable, so I did a radial. So after the radial, everything was fine. So after 1 month, she started developing hypertension. Another AV fistula has developed in the right side. And this fistula became so big that she was developing severe hypertension, hypertensive heart failure. And ultimately, I had to refer to vascular surgeon, and they ligated it.
Great. All right. So thank you very much, Dr. Maher. Thank you everyone for active participation. That's what we want. More discussions.